you guys have such a well-streamlined program here. We're doing, just as a quick plug for our neurovascular conference, so that if you want to get more stroke education, March 1st, 2019 is going to be our conference in Seattle. And I'm sure Kelly will keep you updated if you're interested in hearing more about that. But the whole idea of stroke is the face of it, the symptoms. It's hard to know what's going on. We've recognized that stroke happens quickly for thousands of years, as far back as the Greeks. Is the idea that the reason it's a stroke is because it's something that comes on quickly. It's like being struck down, like by the gods. And the idea with that is that because the blood vessels, when something goes on with your arteries in your brain, it happens quickly. So that's really the big symptom that we're looking at. But it was misunderstood for a long time, and a lot of that goes because there's two different ways the arteries can get affected in the brain. And even as far back as the 1600s, they started to have the sense, doing anatomic dissections on people and post-mortem studies, that either the blood vessels could be bursting open or they could be becoming blocked off. And that's a big differentiation in terms of what type of stroke the person's having, and then also now for how we treat it. And then by the early 1900s, we were starting to get a sense that cerebral vascular accidents or strokes could be caused by bleeding or blockage, and that how we treated them was different. Hemorrhagic stroke has always been a bit of the orphan in the stroke world, and that's because the treatments are not always as effective. There's so much excitement right now about large vessel occlusions and quickly getting TPA and thrombectomy, and we see how well these patients do. But going back to 1961, this paper by a British surgeon, he was actually diagnosing hemorrhagic stroke on the basis of an angiogram and seeing how the arteries were shifted over. So didn't even have the benefit of a CAT scan to know what was going on. But these patients would do so poorly that he thought, well, maybe if we see what looks like our classic hemorrhagic stroke, if we offer them surgery, do a craniotomy and take out the blood clot, maybe we can get the pressure off the brain and see if they improve. And unfortunately what he found is that the patients he operated on tended to do less well even than the ones we just left alone. So that was kind of the start of this idea, well, maybe hemorrhagic stroke, we should just leave it alone. But a little bit what I'm going to go over is we've actually got some new developments that show maybe we have some new treatments that can be helpful. But the big thing is identification. So as Dr. Milford went over, there's the two big categories. Actually, about 80% of strokes are ischemic or blocked artery strokes. But the smaller category of strokes are still really important because the treatment is so different. So just regular spontaneous intracerebral hemorrhage, which can be from some underlying lesions. That's why it's still important to get that CT angiogram, about 15% of the strokes. And then subarachnoid hemorrhage, which typically we think about as being a ruptured brain aneurysm, is the other 5%. So what do strokes look like? This is a big thing, again, when we're seeing the face of the stroke. A blocked artery stroke is going to be very classic for whatever territory that artery serves. So it's the right side of the brain or the left side of the brain or the posterior fossa. The symptoms are going to be fairly classic. Intracerebral hemorrhage is a little different. We still have whatever part of the brain being affected by the blood is going to contribute to the symptoms, so right or left, or versus being the back part of the brain. But the other thing that comes on is the blood is increasing the pressure in the brain. So there's going to be onset of headache very commonly, nausea, vomiting, feeling unwell from that pressure in the brain. With subarachnoid hemorrhage or ruptured brain aneurysm, people are often going to describe that sudden onset of the worst headache of their life. That's just, if you hear that story, we have to be really suspicious that there's something going on like bleeding in the brain. And so in our guidelines, how do we manage these patients? Well, in the field, it's often very challenging to sort out what type of stroke is going on. And so it's still early identification, rapid triage process, getting quickly to the emergency department and then getting that imaging, because that's ultimately how we're going to know, is this a hemorrhage or is this a blocked artery? And then make the decisions about initiating early treatments. In terms of managing these patients, again, in the field, before we have those scans, we have to treat them in some ways very similarly because we don't know yet, is it a blocked artery or is it bleeding? So we want to do our regular ABCs. We know that maintaining oxygenation and blood pressure control are important, and then working to get them into the emergency department where they can be evaluated. And then once they're in the emergency department, taking a good history, try to sort out what's going on. Especially figuring out things like, are they taking any blood thinners is always an important thing for us, especially if there's a chance that there's bleeding going on, something that might need to be reversed. So our pre-hospital stroke scores can help us with having a sense of how severe the stroke is, and then again working on getting identification. So as I mentioned, intracerebral hemorrhage is the more challenging type of stroke in some ways for us right now. It's because it remains a really devastating disease with more limited treatment options. Even though it's only about 15% of strokes, the outcomes tend to be worse than for the blocked artery types of strokes. This leads to a lot of disabled survivors. And so we use a number of different evaluations when the patient comes in to try and predict how they're going to do in the hospital. The intracerebral hemorrhage score, or ICH score, looks at a number of different components. What's their presenting level of consciousness? How big is the hemorrhage? Where is the hemorrhage? The age? And this correlates with their likelihood of survival over the next month. But there's not a lot of these factors that we can really modify. But the hemorrhage volume is one that we've always intuitively thought, well, if we could have a smaller volume, these patients should do better. We know that if their natural hemorrhage volume is smaller, they do better. And so this is why there's still some interest in, are there ways we can reduce the size of the hemorrhage? And we know that smaller volume hemorrhages tend to have higher survival, which kind of intuitively makes sense. But what we haven't found a great way yet is if someone has a big hemorrhage, is there a way we can safely make it smaller? So there's a few things that we can do. On the medical treatment side, there's been a number of trials looking at blood pressure control. A lot of these are hypertensive related hemorrhages. So if someone comes in at 240, 260, systolic pressure, should we aggressively lower that pressure or more moderately lower it? And unfortunately, most of this data has been a little equivocal. So we do have goals and targets, and so it seems that it's probably safe to bring them down to 140, although there can be other end organs that get affected, like the kidneys in someone who's been chronically hypertensive. So certainly at least less than 180. Then we've also looked at trying to control the expansion of the hemorrhage. One trial was this FAST trial where we actually gave a clot stabilizer, this factor 7, to see if we could make the clot stop getting bigger. And what it showed was it ended up having more risk of causing clots in other parts of the body. So for just general people who aren't on blood thinners, it probably didn't help. It was a bit of a wash. Even though the clots didn't get bigger, they had a DVT or some other complication that ended up making it no clinical benefit. So our current guidelines say that if someone is on a blood thinner, get it reversed. And so typically now that we have prothrombin and complex concentrates, we want to use that. That's the fastest thing we can give if the person's, certainly if they're on Coumadin, that's what they need. And then a more challenging situation is these novel oral anticoagulants that we see a lot of people on now. Those ones still, the guidelines tend to be to give PCC, with the exception unless there's a direct reversal agent, as a few of the newer medications are coming out that are direct reversals for that. And then they should be monitored in an intensive setting where they can be managed. That's essentially all we have in our guidelines. So what about on the surgical treatment side? Well, as I mentioned, this 1960 trial showed, there probably wasn't a lot we could do surgically. But as we developed better imaging, CT scans, knowing right where the clot was, we revisited this with the STITCH trial in 2005, again doing craniotomies, and then it actually still showed that with our big surgery, it doesn't seem to help. At least for deep hemorrhages that are located deep inside the brain, we probably have to go through too much brain tissue to get there to take it out to really have much of a benefit. So the subgroup in that was, well, what about those clots close to the surface? So we tried another trial, STITCH 2, and said, well, the more superficial clots, maybe if we do craniotomy and take that out, it'll help. Again, it didn't seem to show any benefit because because when we do surgery, even though the clot's close to the surface, we're manipulating normal brain to get there, probably more normal brain than we think. But the STITCH 2 investigators, they said, well, at least it was a wash in our second trial. We didn't seem to be harming patients, but we didn't show benefit for surgery. But they evaluated all the trials looking at trying to do surgery for intracerebral hemorrhage, and they came up with this graph. And to the left of that line is patients who did better with surgery. And the interesting thing is, at least in these small case reports, these aren't big randomized trials, those are all minimally invasive surgical approaches. So instead of doing a craniotomy, this is people doing small holes and either guiding a sheath in or stereotactically placing some type of a catheter to get the clot out. That seemed to show some benefit. So going back to the guidelines, right now the only people we know should get surgery if they're having bleeding in the back of the brain. That one in the cerebellum, that location, that's going to be fatal really quickly. And so surgery helps those patients because we can reduce the mass effect on their brainstem. But otherwise, we don't have a lot of good data, although they did say that looking at minimally invasive clot evacuation, it's considered uncertain and investigational, but it's worth looking at because there seems to be some early evidence showing that it may help. And so there's been a number of different ways we we can do this. One is we talk about pharmacologically based clot removal, which is where we still do surgery, pass a little catheter into the clot, and then put in a clot busting agent like the TPA, and actually let the clot drip out over time. It takes a few days to go away, but it's a fairly small path into the brain, which is nice. And the other minimally invasive approach we can do is a slightly larger hole, but we'll guide a sheath in and either use a camera or some type of a probe to go in and remove the clot more directly. And the advantage is it gets the clot out right away. But again, it's a little bit larger surgery than just putting that catheter in. But this is certainly where we have interest, and we actually have a trial going on that I'm going to talk about in just a little bit. So we have some early data. One of the big pieces of data it's a study that's already into its third phase. Is called the MISTIE, which is just minimally invasive surgery. It's that pharmacologically based, so putting a catheter in to try and drip the clot away with TPA. The first two phases were completed and look quite positive. The way it works is it takes patients that have at least 20 cc volume, so fairly at least large enough hemorrhages to be clinically significant, so they need to have stroke symptoms or a lowered level of consciousness. And in the first and second phase, they enrolled about 100 patients, and they were putting the TPA in every 8 hours. There's certain criteria that they needed to have. You needed to have that CTA, so we're talking about why is CTA important. Well, if someone has an arteriovenous malformation or some other weakness of the arteries, you don't want to go putting a clot buster in there. That's going to be a very bad outcome. And then the clot couldn't be rapidly expanding. So it's another place that we use CTAs to look for something like a spot sign, which is an artery that might still be leaking, even though it's not a full malformation. And if that's going on, again, we don't want to do a minimally invasive procedure or put, something that's going to destabilize the clot. But once the clots were stable, like the one on the left there, you can see they would advance a catheter in, they would wash the TPA through, the TPA would help the clot to drain out, and then over the next 2 or 3 days, the clot volume goes down, and you can see the mass effect on the brain is reduced. And so compared to the medical group who didn't get this intervention, their clot stayed about the same size over that first 3 days. Compared to the treatment group, you can see the clot volume has gone down. So again, we're getting the volume of blood out. And when we looked at how these patients did, there was an improvement. This is going back to that modified Rankin scale again, just an outcome score for how functional these patients are. With surgery, there was an improvement. There's still a lot of patients that had poor outcomes, but this was a strong trend. And then we broke it down by how much clot you got out. There is even a better trend. So if there's less than 10 milliliters of blood clot left, you can see that those patients did the best. So this suggests that doing better surgery, getting more of the clot out probably helps even more. And this translated into a big in-hospital improvement in outcome. These patients were in the ICU for a shorter length of time and in the hospital length of time, and then this is a shorter cost savings. So for these patients that are otherwise quite disabled, this was a nice trend to see. And this is just showing that outcome, medical versus surgical, quite an improvement in terms of the number of functional patients. Now there was slightly higher rates of bleeding, and you can imagine putting a catheter in, putting surgery in, there was more bleeding in the group that got the treatment, but most of the time that wasn't symptomatic. But one issue with that type of surgical approach is you had to take a lot of patients to find people who qualified. So there's another part of this trial that looked at just putting in a stereotactic sheath and then directly aspirating, trying to get the clot out faster. And on average, they had pretty high evacuation rates, close to 70% of the clot usually came out, and similar outcomes. So that was, again, encouraging, but they didn't go more into that surgical arm while they're doing this pharmacological arm. But what we've been doing at our site and a few other sites across the country is looking to reduce the hemorrhage volume more quickly by using similar inclusion criteria, but directly mechanically removing the clot. And so what we use is our navigation system, which is a computer system in the operating room to show us right where our sheath is going, and then an endoscope so we can look directly down there, and then using a probe that goes in there to help suction the clot out. And so what we do is we place that sheath down into the clot, we use our camera, and then the wand. And so there was an initial generation of this that was called the Apollo device, so after the Greek god, and it was a little bit bulky and clumsy. It worked pretty well, but there ended up being a different device on the market called Apollo. So the company instead of being sued, decided to change it to Artemis. And so I didn't know this, but Artemis is actually Apollo's sister. And so she was actually born slightly before Apollo. They were twins. And she, again, being Greek gods, strange stuff happens. She had to help deliver Apollo. So it doesn't always get as much acknowledgement. But this is our new system. It's now called the Artemis system. And it's much sleeker and easier to use in the operating room. And the handle is quite a bit more effective. So it works in the same way, though. So essentially, I'll take you through the steps of an operation. What we do is we use our planning software to identify. It's a little hard to see where the hemorrhage is, but this goes right down the long axis of the hemorrhage. We're planning where we're going to go. So we select that trajectory, and that tells us where the burr hole is going to be. The other thing we have to account for is what part of the brain is most functional, how can we get there safely. And that's the advantage of a minimally invasive approach. We can avoid those highly eloquent parts of the brain and take a track that's going to go through more clinically silent brain. So that's what we're doing with our planning. And then we register the patient, and we register all our equipment. That's the endoscope. It's got that little array on it so that the navigation system can see it. It goes on, hooks up to the light source, and we have the camera and then our probe there. Those are all the pieces of equipment we're going to use. Again, too bad because of the light, it's a little hard to see. But what we're doing is we're registering against the patient, going back to our trajectory, and then we create the burr hole in the area that is going to get us along that long axis of the clot. We place the sheath down into the deep aspect of the clot, and then we go and we advance our camera. And what we're looking at is we're looking at both, you can see in the top right there, the endoscope, so we're actually seeing inside where we are in the brain, and then where our navigation system tells us we are, so that we're not manipulating into normal brain. And this is what it looks like looking down the endoscope. Again, a little hard to see with that light on, but essentially dark clot is what we've got deep inside the brain, and that probe is helping us to get it out. We use irrigation to wash through, help wash some of the clot away. Also, if there's tiny little bits of bleeding, it helps us get hemostasis. And so we're suctioning out those pieces of clot there. And the probe has a special vibrating piece inside it that helps break down those clots. And so then once all the blood's been removed, we're seeing the normal white matter of the brain underneath. And then we aspirate and we pull our sheath back, and then eventually what we're doing is just creating a cavity where that clot was. And so once we've removed all the blood clot visibly, we'll bring in either a portable CT scanner, or if we're in our hybrid room, we can get or in the IR suite, we can get a picture of the brain to make sure we've removed as much of the clot as we thought we did. And so at the site that I was working at, we had done quite a number of these cases, and so we analyzed how we were doing just in our a single series. We're calculating the volume of the clot based on kind of a simple volume calculation, and comparing pre and post-op volumes, again wanting to get as much volume out as possible. So that was sort of our patient demographics. All these patients were significantly impaired, GCS 10 on average, and they all had significant neurologic dysfunction, and their ICH scores on average was 3, which predicted fairly high mortality at 30 days. So the average volume of clots was about 55 cc's, and post-op we reduced that on average to 10 cc's, which is about that goal where we think we're getting the maximum clinical benefit. We also measured how much shift there was in the brain from the clot, and we could see that when we removed the clot, we were immediately seeing a reduction in the shift, which is one of those things that it's not quite like a thrombectomy where the patient wakes up and gets back to normal. There's still injury to the brain, but by getting the shift down, if the patient's more awake, they can start participating in things like rehabilitation therapy. They can get extubated, and that helps them have shorter hospital stays. And so these were our average hospital stays that we saw, fairly wide range because some patients are still there for a long time, but we saw a lot of our other patients waking up more quickly. And in terms of our good outcomes, actually a similar finding, similar percent to in that ICES study, the other arm of MISTIE, the mechanical arm. We had a couple of patients that did have some rebleeding afterwards. Both of them had been on, they were actually thrombocytopenic low platelets, both actually in this case from alcohol abuse. And so I would probably not tend to operate on patients who are going to have a high risk of rebleeding. They're probably not the best candidates for this. There's another multi-center review, smaller number of patients that had come out looking at this. But I think overall what we see is that there's certainly an advantage of getting out that volume of blood. The challenge any anytime we're doing minimally invasive surgery, it can be harder to control hemorrhage. We really have to make sure we're selecting the right patients. But I think the big thing is people are so cautious about doing surgery because none of our trials have been positive before. So although both the MISTIE trials and our data seem to suggest that it helps, what we need is we need a randomized controlled trial. And fortunately, there's one that just started this year. And so it's called the MIND trial. So it's using the Artemis device. We're planning to enroll 500 patients across the country. There's going to be quite a number of sites. And we're looking for patients that meet these criteria. So again, that moderate volume, 20 to 80 cc's. So it can't be a devastating hemorrhage where we don't think they're going to survive, but the moderate hemorrhages, but where they're significantly neurologically impacted because of the pressure of the blood. And they need the CT angiogram to confirm that there's nothing underlying that caused it. And so we've been selected as a site. We've had a couple of patients already. We've screened a number of patients, but we're certainly looking for these patients. We're always happy to talk if you think there's someone who might be a good candidate. And so of the patients we've treated, they've both technically gone well. We've treated a couple other patients before the trial got started. This was one of the examples. So you can see the blood comes out fairly nicely and the mass effect is reduced. And then here's a large lobar hemorrhage that was removed. So I think that, as I was saying, we're going to need really strong data before this becomes accepted. This is not quite like thrombectomy, where we show that, you get that blood clot out, that person goes from, complete blockage to all their blood flow back, and they start to get better. Here, the recovery process is longer, but we probably help speed it up by getting the blood out. And I think we're hoping that that's what our trial is going to show. So I'm going to shift gears a little bit from the spontaneous hemorrhages to hemorrhages that are like this, but that may have an underlying lesion. And that can be as high as 5 or 10%. So that's why it is important to get that CT angiogram. Again, because one of the more common ones that we see, especially in younger patients, is going to be an arteriovenous malformation. An AVM is just an abnormal connection between the arteries and the veins in the brain. And that nidus or tangle leads to a weak spot, leads to dilated veins. So instead of going through the normal capillary phase, the arteries, which have a strong, thick wall, are plugging directly into the veins with their thin wall, and hence why there's that risk of bleeding. So the treatment for arteriovenous malformations, there are a number of different choices. So endovascular therapy, we can go into the artery and get a catheter up close to it and inject an embolic agent, try to essentially like gluing the feeding arteries. We can do surgery where we go and disconnect it, or we can do radiation where we stereotactically guide beams of radiation, help it scar down. Issue with radiation takes about 2 years to work, so typically we use that for AVMs that we found incidentally, not for ones that have hemorrhage. Typically, if it's had a hemorrhage, needs to be treated sooner, we're going to probably try and do a combination, try and embolize what we can, and then do surgery to remove the blood clot and the lesion. So this is an example of a man who came in. Again, unfortunately, these pictures are not going to show up really well, but this was his scan showing that he'd had hemorrhage up in this area here. So over the top of the brain, where in the motor homunculus, it's going to affect, more likely to affect your leg. So his left leg was most affected. We saw the AVM, and so we did an angiogram test. We could see this abnormal nidus or tangle of arteries up there. And so we put in some embolic agent to embolize it. There's still a small feeding vessel, which we could see coming out the top as an early draining vein. So then we planned to take him to surgery, and so at the time of the operation, we exposed, and we're looking at a number of different things here. You can see that this is much darker. This is actually some of our embolic agent inside, but then it can be hard to tell, well, which is the feeding artery, which is the draining vein. And so what we can do is inject dye into the patient's vein, and we watch it flow, then first pass through the arteries. And so the first thing to show up under the microscope with a fluorescence filter on is the arteries. Then we see the early draining vein show up, so we know that that's how the blood is getting out of the vein, out of the AVM, and then the normal veins show up last. And so we have to preserve that draining vein coming out of the AVM so that it doesn't burst. So then we dissect around the nidus, work around it, create the cavity, and eventually that vein goes dark. And so once the vein goes dark, we know the nidus has been removed. We're back to just normal venous phase, and then we clip the draining vein, and then we're essentially finished. We do an angiogram to confirm, and then the AVM is out. And then you go back to the intensive care unit for very close blood pressure control. Such a critical part of recovery after an AVM is tight blood pressure control postoperatively. So now we're going to move to the third phase. Everybody good so far? Yeah, the subarachnoid hemorrhage is another big category, and although it's fairly rare, it's another very important one because typically this is going to be from a ruptured brain aneurysm. So a brain aneurysm is just a weak spot or a dilation on the artery. And it's because the normal artery has multiple layers, but the aneurysm does not have the muscular and elastic lamina layer, and so it's a weak spot. Most aneurysms are these berry-type aneurysms or outpouchings. Sometimes we see where the whole wall of the artery is abnormal, and some very tricky ones are these blister-type aneurysms, where this is lacking also all the endothelium as well. It's just very, very thin here. And these are challenging to treat by any of our means, either surgery or endovascular. But we've got a few new strategies that I'll talk about how we can deal with those. Now, many aneurysms, when they come in, are actually unruptured. Those ones we can be more relaxed about. They're often asymptomatic. We may find them, we're doing a scan for some other reason. Maybe even the patient is having their ischemic stroke, but gets a CT angiogram and has an aneurysm as well. It doesn't usually need to be treated at the time, but we need to be aware of it in case it needs treatment in the future. So we often follow it and then discuss the treatment options. The ruptured aneurysm is the one that's a real emergency. This one is dangerous, and so we have to identify those. So one of the questions we say, just like when we go back to the patient coming into the emergency department, a lot of people have headaches, just like a lot of people have dizziness. So, but the subarachnoid hemorrhage is a little bit different. They often say it's the worst headache of their life. Almost 80% of people say that. But almost 2% of emergency department visits are for headaches. So how do we tease that out? So one thing we can go back and say, well, do you get headaches? Are headaches normal for you? Is this your normal headache? If it is, that's much more reassuring. But if it's, no, I never get headaches, this is out of the blue, or I get headaches, but this is different, this is something much worse, then we should be more suspicious. So there's some clinical guideline rules. The Ottawa subarachnoid rules, one that was created to help sort out, we'll get a CAT scan. So if you have someone who comes in and actually has a new neurologic deficit, that person needs a scan. That's very clear. It's that headache that's a bad headache, but the person otherwise looks normal. Do they have any of these features? If you're over 40 and you have neck stiffness, because the blood in the subarachnoid space creates like a chemical meningitis, if you passed out at any point, if it came on during straining or exertion, and if it came on very quickly, all those things are risks for it being a subarachnoid hemorrhage and should get a CT scan. If it doesn't have any of those, then it may not need a CT scan. It might just be a typical bland headache. So ruptured aneurysms, well, why do we say they're dangerous? Well, the overall mortality is about 25 to 40%. Up to 15% of people die before they make it to the hospital. Half of survivors have significant deficits afterwards. But what's really bad is if the aneurysm bleeds again. So typically what happens, the aneurysm bursts, you get the symptoms, but blood clot will form over the surface. The pressure that goes up in the brain that creates a severe headache also tamponades the blood over top of the aneurysm. But now you have just this thin clot protecting the aneurysm. And if that aneurysm rebleeds, the mortality rate goes up to 70%. So that's why we want to do everything we can to prevent an aneurysm from rebleeding. And the risk of rebleeding is highest right after it's happened. So 4% in the first 24 hours and then 1 to 2% per day for the first 2 weeks. So about 30% at a month. So we want to identify this and treat it as soon as we can. How do we find out that they have a subarachnoid hemorrhage? Well, getting that CT scan will show this pattern of blood. All the white is the blood, very classically in the basal cistern, so blood in the spinal fluid spaces. Sometimes patients, this is a very obvious and dramatic one, sometimes the patient has a very suspicious story, but the CAT scan's a little uncertain. And the other issue is, when was the CT performed? If you can do it within 6 hours of the onset, it's very high sensitivity. You're almost never going to miss blood with just a plain CT scan. Once you get outside of 6 hours, you're always producing spinal fluid. You make 1 or 2 cups of spinal fluid every day. It can wash the blood away. And so in those patients, if you're after 12 hours, a very suspicious story, but we didn't see any blood on the CT scan, it may still be worth getting a lumbar puncture. That's really still our next gold standard diagnostic tool. And what we'll see is the blood actually stains the perfectly clear spinal fluid a yellow color, and that yellow we say is xanthochromia. So when it goes to the lab, it's very important they specify that for us. So if someone has a headache, it's not so much that we're looking for still a high blood cell count, although that could be present. That can be confounded by, you could have a traumatic tap. But if they spin the fluid down and it looks yellow, the blood was there for at least 12 hours in order to stain the spinal fluid. Xanthochromic spinal fluid, we have to treat it as if it's been a ruptured aneurysm. And then we go on to some kind of confirmation test like a CT angiogram or our catheter angiogram. So some people now have been advocating, well, the lumbar puncture can be uncomfortable. What about just going to a CTA? So if that is really the debate. If you have essentially a normal looking CAT scan, it's over 6 hours, do you move to the LP or the CTA? Probably either is good. The LP is still considered our gold standard right now, but CTA will show us anatomically if there's an aneurysm there. So once we identify there's an aneurysm, what do we do in order to prevent rebleeding? We have to get the aneurysm secured. It's either clipping or coiling. And then the other phase of treatment is preventing all of the side effects that the bleeding causes. The big thing that happens after the aneurysm is bled, all the arteries are inflamed and irritated and can go into spasm. And then there's a whole host of inflammatory conditions that can go on. When these patients come into the emergency department, they can have a whole bunch of changes. So we think of that as two different phases of care. One is before the aneurysm is secured. The main thing we're doing before we can get to surgery or coiling is to keep the blood pressure under control. And then after the aneurysm is secured, managing all the other side effects. So once we make the diagnosis, so we know that there's subarachnoid hemorrhage there, we put them into precautions. So we don't want them to be stimulated. We don't want anything that could spike the blood pressure and knock that little clot off of the aneurysm and cause it to rebleed. Sometimes these patients, however, are have lost their level of consciousness and they need their airway secured. If they're going to be intubated, that needs to be done very cautiously. The laryngoscope very stimulating, and so we often will have them spray lidocaine and really try to have it as little stimulation as possible when they're intubated. Blood pressure should be less than 140, and then we get labs. Many of these patients have had cardiac side effects, and so they may need an echo and ECG. If they need to be transferred, there's some debate about this, but in the guidelines right now it says it is reasonable to start a clot stabilizer like tranexamic acid if the patient needs to be transferred, and that's only until the aneurysm is secured, and then we stop it afterwards. It's kind of like the factor 7. We know that putting long-term clot stabilizers on has a risk of causing DVTs and other side effects of hypercoagulability. So just stabilize the clot until it can be secured. Usually we'll start seizure prophylaxis with Keppra. We don't give Dilantin. There's more side effects with Dilantin. And then we get them transferred somewhere that it can be clipped. Many of these patients will also have hydrocephalus, and there's a couple of options, either putting in an external ventricular drain or in some cases a lumbar drain to manage their spinal fluid, which, as we said, you're making 1 or 2 cups a day. The blood can slow down the absorption if that builds up and can make people be in a coma. And so what are the treatment options? So the traditional method was surgery. You need to do a craniotomy, go down, find the neck of the aneurysm, and put a titanium clip across it. The nice thing about that is we know it's a really durable treatment. We know the aneurysms have a low chance of coming back, but it's more invasive to have a craniotomy, and you need to have your arteries manipulated to some extent, which can worsen the inflammation. So endovascular coiling, we go into the artery in the leg. Dr. Robinson will probably talk a little bit about some of these things in more detail too. But essentially what we're doing is going to guide a tiny catheter up until we get into the aneurysm, seal it with platinum coil so that the blood can't get in, and then it will clot off, and then over time the body will form new endothelium, a new scar basically along the line there to reconstruct the artery. So how do we find this? Here's an example of doing an angiogram. But we have some data right now, just going back to the 2 treatments. It's sort of a yin and a yang. Each aneurysm we have to assess. Some are better for clipping, some are better for coiling, and it's always a discussion between the treating team about which is best. If it seems to be equal, we probably have some data that coiling is better, and it's probably because it's less invasive. So here's an example of how our more modern imaging equipment can help us better define these aneurysms and then treat them. This is an example of a MRA that the patient had because he had high creatinine, so he didn't get the CTA. And we can see here's the carotid artery come up, and the anterior cerebral artery, and then an aneurysm in that area there. When we do the 3-dimensional angiogram, it's much higher resolution. You can see it's actually a bilobed aneurysm here, so with 2 little domes to it and a little rotation there. And then because we know what it looks like, we can go up and support the neck with a balloon, get loops of coils into both of the domes in the aneurysm, and have the whole aneurysm secured that way. Certain aneurysms, when they come in and when they rupture, they have not just subarachnoid hemorrhage, but also hemorrhage that goes into the tissue of the brain. That's more of a problem because it's causing more mass effect. And in addition, we still have to know what the shape of the aneurysm is like. On the CT angiogram, we were a little surprised, even though she had a fairly large clot out there. You can see it's a fairly small aneurysm. Those small aneurysms can actually be really tricky for coiling because the coils don't want to stay in, and they could block off one of the normal arteries and cause a stroke. And so this one, when we assessed it, we did an angiogram on it. You can see it really is just a small kind of bilobe, little bunny rabbit ears almost there, aneurysm. That one's going to be really tricky to treat with coils. So we decide to go to the operating room and we convert to doing a craniotomy. So the patient's positioned. We go in and bring in our operating microscope. The microscope view looks pretty red with the lights on here, but here's the aneurysm, here's the artery coming up, the aneurysm, the two lobes of it, and we go and we place our clip, the titanium clip, to secure the aneurysm. Now we want to go back and make sure that the angiogram shows what we expect, that there's good blood flow in both arteries and that the aneurysm is secured. So there's the aneurysm before we do our follow-up angiogram. There's the clip, both branches are open and the aneurysm's gone. So that's essentially what we're looking for. And then I said the last category of aneurysms is quite tricky, is those blister aneurysms. When they've come in and ruptured, they're so thin, our coils may want to push through them and our clips may want to tear the artery apart. But this is again how the technology coming along has really helped us in the treatment of these. This pipeline device, which you can see is a flexible stent, we can put this into certain arteries. It'll keep branches open because it's like a mesh, but blood goes in, has trouble getting back out. And we don't actually have to go into the dome of the aneurysm. So for certain aneurysms, like those blister aneurysms, this has become a really effective treatment. Here's a 37-year-old lady. She was sudden severe headache, but otherwise in good condition. The CAT scan, I hope you can see her, bright white extending up this area, so she had clear subarachnoid hemorrhage on her CAT scan. She had the CT angiogram done. Here's the carotid artery. It's like a side view here. We can see it just looks very irregular in this portion underneath there. We take her and we do her initial angiogram, and we see this thin blister type aneurysm off the bottom. That's going to be a very challenging aneurysm to treat. The coils aren't going to want to stay in it, and treating it with surgery is very high risk. So once we stabilize her for a day or two, make sure she's not going to need an external ventricular drain placed. Once we have that, we're able to put her on aspirin and Plavix. So we have to thin the blood to use these stents. So we have to make sure these patients are stable. It can make you a little anxious, especially in someone who's had bleeding. But for the most part, if they've stabilized and we kept their blood pressure under control so far, most of the time it works. It's probably the best treatment option of balancing the risks. We place the pipeline stent. You can see that initially after the pipeline goes in, there's still some filling, but what we're getting is some early flow diversion. We take her back, this is at 7 days, and then at 6 weeks, the aneurysm is essentially gone because the blood is clotted and the artery is being remodeled. We can see that the artery is a little bit narrow. That's because the reason it's remodeling is there's a new layer of endothelium growing inside it. So we have to watch carefully to make sure it doesn't keep narrowing. But in fact, when we bring her back at 6 months for follow-up, now the arteries, the endothelium is flattened out, the artery looks back to its normal size, and the aneurysm is gone. And here's a CT angiogram at 18 months, again looking good, and the aneurysm is still gone. So that's a quick run through of hemorrhagic stroke. And this is another reason I don't sleep much. And yeah. Any questions about bleeding, stroke, or things you want to discuss?
What kind of, so are those bare metal stents?
Yeah, so most of these brain ones are just metal. It's a good point. So we need to use aspirin and Plavix. This pipeline one is coming out with a new, not actually drug-eluting, but it's going to have a new device that's coated. It's just in animal studies right now, essentially, trying to prevent the platelets from sticking to it. That's the whole thing. When we put a stent in, we don't want the platelets will stick to it because it's like a rough surface. But we don't have any drug-eluting stents, and they're all made of either mostly nickel titanium alloy or other different alloy combinations like that. Yeah.
So what about MRIs after that?
Yeah, they're all MRI compatible, fortunately. Yeah.
The clips, coils, and the stents?
Yeah, everything now, since it's always a good question that comes up, yeah. Since about 1992, pretty much every device that goes in the brain has been MRI compatible. If it's pre-92, you probably have to check, try and get old records to see. Some things were, if they were titanium, yeah. They were compatible, but titanium is compatible in the MRI scan. And so our clips are titanium and our coils are mostly made out of platinum. So all the coils are compatible.